patient's compliance must also very excellent. The compliance is not in relation to the oral hygiene compliance, but also compliance to dental visit. From the beginning, they have to be told that they have to come regularly throughout, not only during the procedure, after the procedure, but as long as we can, because we need to monitor the regenerated tissue from time to time. Okay. And then in terms of smoking, studies have shown that patient who smokes more than 10 cigarettes per day, 15 cigarettes per day, would have less regenerated tissue compared to non-smokers. So as a guideline, normally we'll, if possible, we will select only non-smokers, but if not, anything that less than 10 cigarettes per day would do. But patient has to know the risk, the risk of to get good regenerated tissue will be less. And then in terms of systemic conditions, any systemic condition that may hamper healing would be, we should be careful with it. For example, in diabetic patients, if they have poor glycemic control, better not. Better don't suggest for any regeneration procedure. Okay, but if the patient has good, glycemic control, then it is okay if it is feasible to do. Okay, in terms of those factors, one of the important factors that we need to check is regarding the endodontic status. Meaning we have to ensure that the tooth is vital, and if not, make sure that we do the RCT first prior to regeneration, because studies have found that with a proper RCT, they manage to get successful treatment after regeneration. And then in terms of mobility, we have to be really careful, because any movement of the tooth will, during the healing period, will disturb the regenerated tissue. So in general, what we do in our clinic, mobility grade 1 will be acceptable, but the tooth has to be splintered prior to GTR. In terms of defect factors, which can be evaluated via radiograph, studies have found that deeper depth have better predictability compared to the shallow depth. And in terms of the width of the defect, studies also found that narrow defect with the radiography angle of less than 25 degrees will gain consistently more attachment compared to the defect wider than 37 degrees. Okay, for example, in this photograph, in this radiograph, if you see this tooth which has a narrow but deep defect would probably have better predictability compared this one which has a wider defect. In fact, in 1995, Cortellini and Bowers have summarized by making this chart showing that defect with narrow but deep defect would have a higher predictability compared to wide and shallow defect. Okay, next is in terms of number of residual bony walls, where studies have found 3-wall defects would have better predictability compared to 2-wall defect or 1-wall defect. As shown here, this is example of 3-wall defect, where this tooth has bone walls at the infrabony area, on the buccal, palatal, and also interproximal. Okay, this is 2-wall defect, where the infrabony defect has only bony walls at the interproximal and also either at the palatal or the buccal. And 1-wall defect is when there is only interproximal bone without buccal or lingual bone. And if you remember from the earlier study that I shared, Cortellini and Tonetti in 1993, where they found that the bone fill in 3-wall defect is 95% from their study. In 2-wall defect, reduced to 82%. And in 1-wall defect, it can reduce to up to 39%. Okay, now the third part of my talk, where we will discuss some of the long-term results, whether is it will need to do GTR, and if the tooth could be maintained for how long so far based on the evidence? Is it only 1 year, or is it up to 5 years, or 10 years, or probably perhaps 20 years? Okay. So among the earliest long-term study that has been done is in 1992 by Gotlow and group, where they have this 5-year result based from 39 patients. But out of 88 sites, 9 sites are being monitored up to 5 years. And what they found that in all these 9 sites, 9 sites of the GTR tooth has stable gain of attachment of more than 2 millimeter. Yeah. But this result was strictly dependent on patients' participation in recall program, and most of the sites has absence of bacterial plaque, absence of bleeding and probing, and no reinfection with the periodontal pathogens. Then in the next study in 2011 by CORTELLINI group, this is a randomized clinical trial of 5 years results where they compare of patient and clinical outcome between GTR group and versus the group where they extracted the tooth but replaced with either implant, conventional bridge, Maryland bridge, and or no prosthesis. Okay, what they found that in test group, 23 out of 25 teeth showed important clinical improvements. Only 2 teeth were extracted at 1 year. The remaining 23 could be maintained up to 5 years. And this 92% of the regenerated teeth were in good health and function, even at 5-year examination visit. And 84% did not develop any biological complications during the recall period, meaning there is no evidence of inflammation, no evidence of pocket formation. Okay. Whereas in the control group, of course, none of the 24 replaced units were lost during the 5-year observation period. And 100% of all the replaced units were still in function and in good clinical condition up to 5 years. So, and in fact, all patients consistently reported comfort in function at the experimental group and also at the control unit. So basically, result from this study, they can say that even if the tooth was not extracted, it still can be almost as good as the tooth that is being extracted and replaced with the prosthesis. Yeah. So this is one of the example reported in that paper where this patient presented with tooth 1-1 with very deep defect, and the tooth is non-vital, and they did the root canal treatment, and then they proceed with the guided tissue regeneration. If you see, there is evidence of severe bone loss, severe infrabony defect up to the apical region, and this is after 1 year. There is formation of the bone at the coronal apical 1/3, and it been maintained up to 5 years post-op. Okay. So conclusion that can be made from CORTELLINI et al. 2011, the first one is that regeneration, okay, will lead to retention of 92% of hopeless teeth, which initially was scheduled for extraction, and regeneration has improved their prognosis. And all these retained teeth has clinically stable parental parameters, still comfort and function for a 5-year period. And for both implant and tooth-supported reconstructive therapy were successful in replacing the hopeless extracted teeth and maintain comfort and function over 5 years. So that because of that, they concluded that parental regeneration is a suitable alternative to tooth extraction in teeth compromised by extremely severe intrabony defects. But please bear in mind that this is based on a very strict adherence to maintenance protocol. Yeah. Then next, CORTELLINI 2017, where they have another study. It's also randomized clinical trial looking at the GTR up to 20-year follow-up. So in this study, they have 3 groups. 3 groups, where the first 2 groups is the regenerated groups, only that the difference between these two groups is in terms of the technique being used, surgical technique being used during the surgery, and type of membrane. And the control group is the one that they only did excess flap. Okay. And what they found that after 20 years follow up, in the first group, 100% survival of all the teeth, only 5 recurrence of the disease happened, but manageable. And in the second group, also 100% survival, but with 6 recurrence. In the third group, the control group, they found that there was a greater attachment loss with 15 recurrence episode and 85.7% of survival, which means because two tooth has been extracted. And in this group, they also found that it involved higher cost for all the reintervention. Okay. So conclusion from that study, long-term health benefits and lower cost of managing parental recurrence of regeneration compared with the excess flap treatment. Okay. Then next study by pet source in 2019, where this is another 20 years post-op by different group, where they treated 44 defects from 16 patients. They compare between open flap debridement, normal open flap debridement with GTR. And what they found is that there was attachment gain in both groups stable up to 20 years. And there were no significant difference between both groups. And in terms the survival percentage of the treated GTR, it was only 79%. Okay, little bit reduced from CORTELLINI study. And then another study by Chiplik et al. In 2020. This is among the longest period of long-term follow-up GTR cases, up to 26 years, where they did. Oh, sorry. Okay. They did they did GTR in 102 defects from 50 patients involving molars, but they selected only molars with no furcation involvement. And they found that results after 26 years, the survival percentage was only 52.9%, still intact. Even lower than the previous two studies. And the median survival of the teeth was 13 years. And they found that patients with diabetes and patients who are smokers will tend to lose more teeth. Okay. And this study have low survival compared to their previous two study due to several factors. Firstly is because that only half of the defects included in the study received supportive parental therapy, which is the maintenance protocol, with at least 2 regular. And in this study also, they claim that they have higher proportions of molars, which is 46.2%, compared to 11% in CORTELLINI and 32% in PetSource 2019. So they concluded their findings by saying that 50% of the initially seriously diseased teeth were still in situ up to 26 years following GTR, despite overall limited adherence to SPT, meaning if patients tend to adhere to SPT better, probably they will get better results. Yeah. And in majority of these teeth, the CAL gain 1 year after GTR could be maintained over this long period. Okay, then CORTELLINI, continuation of earlier study. This is CORTELLINI in 2020, where they look at the 2 different groups, GTR regenerated group and compared to the extracted and replaced by the prosthesis group. But this is up to 10 years. What they've in this report, they report about the survival analysis and also cost effectiveness. They mentioned that they include stage 3 and stage 4 periodontitis patient. So what they found is that in terms of the survival, in extracted group, the survival rate is still 100%, whereas in the perio regeneration group, the survival rate 88%. This is because if you look at this table, if you remember during the earlier study, 2 teeth were extracted during the first year, yeah, which make the only 23 teeth remain up to 5 years. And out of 23 teeth, one tooth has to be extracted at the year 8, yeah, as a consequence of trauma. So end up during at 10-year review, they managed to get only 22 teeth. Okay, in terms of the cost analysis, they found that total cost of treatment for the regeneration group, which includes the cost for the replacement of the 3 teeth that were lost, is significantly lower over the whole observation period compared to the extraction group. Okay. And they also reported on the patient-reported outcomes based on the OHIP questionnaire, which they look at the functional limitation, physical pain, psychological discomfort of the patient, physical disability, and psychological disability. What they found that OHIP score at baseline between these two groups, there was actually no significant difference. But after 1 year, they found that in regeneration group, they have lower OHIP score, which indicate better patient-reported outcomes. Yeah. And in terms of the masticatory function, at 10 years, if you look at this bar between regeneration group and extraction group, you can see more the green color bar in the extracted group compared to regeneration group. This indicates that more patients reported that they have no concern about the masticatory function in the extracted and replaced by the prosthesis group compared to the regeneration group. So they concluded their study by saying that periodontal regeneration can change the prognosis of hopeless teeth and is a less costly alternative to tooth extraction and replacement. Okay. And in fact, I would like to share one of these latest CPG by the European Federation of Periodontology in relation to management of infrabony defects. They have recommended to treat the teeth with residual deep pockets associated with intrabony defects of 3 millimeter or deeper with perio regeneration surgery. And this recommendation based on strong evidence, yeah. And in terms of the material used for the periodontal regeneration, Nibali et al. In 2019 has come out with a systematic review and meta-analysis comparing different regenerative materials, which involve the collagen membrane, enamel matrix derivative, which is the emdogain, bone substitute, and also PRP or PRF, which is under category of the autologous platelet derivative, and also combination. And this systematic review based on 79 RCT study published from as early as 1990s to 2019. And what they found from this systematic review and meta-analysis, they found that of all the material used, enamel matrix derivative, EMD, which is the emdogain, and resorbable membrane is considered gold standard for the surgical treatment of deep intravascular defects. Yeah. And addition of bone graft, bovine bone graft, will improve the clinical outcome of the GTR. Okay, as we are still in the material, I would like to share some of the information related to the autologous platelet concentrates, yeah, specifically concentrated growth factors, because this is what we normally use in our clinic in UITM. So autologous platelet concentrate is a promising application in the field of periodontal regeneration, yeah, because it can improve the healing. It can accelerate the healing because these platelet concentrates contain biologically active proteins, which we believe to be growth factors, and it can create chemotactic gradients to recruit the stem cells, to recruit the to stimulate the cell migration, stimulate cell differentiation, and also promoting repair. And example of the autologous platelet concentrate is PRP, PRF, and latest is the concentrated growth factors or CGF. Yeah, but I will focus more on the CGF. This is one of the interesting study by Gao et al. In 2016. This is a group. This study is from China, Beijing, China, where they did the periodontal regeneration using CGF in 17 patients who presented with probing pocket depth of more than 5 millimeter. So what they did, they processed patients' own blood with different centrifugation speeds, which produce the CGF, and it was claimed that CGF will produce much larger and denser fibrin matrix, which is richer in the growth factor than typically found in the PRP and PRF. Yeah, and these concentrated growth factors also has been found to have high number of CD34 positive cells. Yeah, CD34 is one type of the hematopoietic stem cells and have been demonstrated to play very important role in vascular maintenance and also new blood vessels formation. Okay, in this study, the control group they did not apply the CGF, only the bone graft, and in this study, okay, this is the CGF being produced after centrifugation of patient's own blood. And this fibrin block will cut into pieces and they mix with the bone granules to form the sticky bone. And this sticky bone is easier to handle, yeah, during surgery. And another part of the this fibrin block will made into membrane shape, which I will show you after this. Okay. So this is the defect, example of the defect area, which is reported in Giao 2016. They fill the defect area with the sticky bone and they cover this sticky bone with the CGF membrane. This is the result that they get, example of one of the case. This evidence of infrabony defect, and this is after 1 year post-op. Okay. And in terms of the clinical measurement at 1 year post-surgery, they found that in CGF group, there is the probing depth reduced to 3.1 millimeter, whereas in the control group is 4.5. And these two, the difference between these two groups was statistically significant. Other studies that have been using concentrated growth factor is Isler et al. In 2018, where they also found there is actually no significant difference between using bone substitute and collagen membrane, which is the GR, versus if they use bone CGF. But they used this study was being done in a peri-implant defect. Yeah, and another study by Zhu et al. They used CGF in periodontal intrabony defects, and they found that they found positive results. And when the CGF mixed together with the BioOS, CGF could show better results, and the effect was more stable. Okay, then I would like to show some of the cases that we manage in our clinic. Yeah. The first one, which is managed by one of my periodontal resident, Dr. Nurzetti. This is a female, 24 years old, which claimed to be medically fit and healthy. She complained of gum bleeding during brushing, and she is also a regular dental attendee. And upon examination by Dr. Nurzetti, she found that this patient presented with BPE score 4 of all the sextant, which means that most of the teeth had presented with pocket depth more than 5 millimeter. And plaque score of this patient was 36.6%, and the bleeding score was 36.9%. And this is the periodontal charting. If you see, this patient presented with probably pocket depth as deep as 7 millimeter, and even 10 millimeter and 8 at the area of tooth 2-6. And then at the area of tooth 3-6 was 8 millimeter. Yeah, incisors was also around 8 to 7 millimeters. And for 6, the pocket depth was as deep as 9 millimeter. This is the radiograph at baseline. If you look at the tooth 4-6 mesial, there was evidence of infrabony defect. Similarly, at 3-6 area, 1/6 meso still. This is the full mouth periapical radiograph for better view. You can still see, yeah, evidence of infrabony defect here, molars, and also some horizontal bone defect involving incisors. So Dr. Nozetti have done non-surgical therapy, which involved the oral hygiene instruction and also scaling plus through debridement. And during review, patient presented with remaining deep pocket, yeah, at the molar region. Okay, as presented here at tooth 1/6, patient still has 6 millimeter pocket at mesial buccal and distal buccal, and 7 millimeter at mesopalatal. At tooth 2/6, patient presented, yeah, after review with 8 millimeter on the mesiobuccal and 6 millimeter on the mesopalatal. At tooth 3/6, 8 millimeter on the mesiobuccal and 6 millimeter at mesolingual. And tooth 4/6, 6 millimeter on mesiobuccal and 7 millimeter on mesolingual. And during this time, patient has a very good oral plaque control. So we suggested for GTR. So during GTR, we did modified papilla preservation technique, which suggested by Cortellini in 1995. This is in order to achieve and maintain primary closure of the flap in the interdental space. And as apart from that, it is to increase the space for regeneration. But this modified papilla preservation technique is indicated in area with space width of more than 2 millimeter. So this is an example of when flap was elevated. Okay, at area 236, we can see the evidence of infrabony defect. And this is when the membrane was placed. We place the membrane first, then only we put the bone graft underneath the membrane. Yeah, then we suture the flap. Among all the four sites, because tooth 4/6, we see that this the defect was quite wide. Yeah, the it's quite wide. So we are thinking of we were using concentrated growth factor in terms to help in the healing. So this is the example of the defect at tooth 4/6. And this is the patient's on blood that has been centrifuged to form the CGF. And this is when the CGF has been made into a membrane shape. Yeah. So what we did, we placed the bone graft and then we cover the bone graft with the CGF membrane before we place the collagen membrane. And then we cover with the flap. For post-op care, we follow Untitled in 2000, where we give antibiotic for 1 week. Then we ask the patient to rinse with chlorhexidine 2 to 3 times daily. And patient must not have any mechanical cleaning at the treated area for around 6 to 8 weeks, and must not chew on the surgical site during healing period. And patient has to come weekly professional tooth cleaning and monthly review. And we only probe the area after 1 year, yeah, after 1 year follow-up. So because of that, all the procedures have been done in year 2021, and only this tooth, yeah, has been done at late 2020. So we managed to probe this area, and results after 1 year, we managed to get a reduction in probing pocket depth, yeah, from 6 millimeter on mesiobuccal has been reduced to 3 millimeter, from 7 millimeter at mesopalatal also been reduced to 3 millimeter. And in fact, from the radiograph, you can see evidence of bone in the defect area. For other teeth, because it's not 1 year yet, so we couldn't have presented the probing pocket depth, and what we can show here is evidence from the radiograph, okay, for tooth 2/6 and tooth 3/6 at 5 months post GTR. Okay, if you can see here, this area. And then for tooth 4/6 at 8 months post GTR, this is evidence. This is the one that we use the CGF. Okay, This is the second case managed by another perio resident, Dr. Yuliana Ayub, where this patient, around 44 years old man, presented with periodontitis and few hopeless teeth. And after series of non-surgical management, we are concerned about this defect area, at tooth 4. Okay, and at baseline, this tooth was non-mobile but presented with deep periodontal pocket depth, which is 9 millimeter on the distal lingual and 8 millimeter on distal buccal. And after non-surgical management, the tooth has become still non-mobile, and the probing pocket depth reduced to 7 millimeter on the distal lingual and 3 millimeter on the distal buccal. And during that time, patient's blood control has improved to 15.9. So we suggested for GTR. So Dr. Yulana, this is has managed this case during the surgery. This is the example of the defect area. It's considered two-wall defect, because the lingual wall almost not there. And we use patient on blood to produce the CGF, and we place the bone graft with the CGF and also the membrane. Then this is the result after 2 years. We managed to get the bone, Okay, third case, managed by one of my senior colleague, Professor Fuad Abayati. This patient, which is his patient, Prof. Fuad's patient, is a 60-year-old man, claimed to be medically healthy. He has tooth 1.5 as one of the abutment for 5-unit ceramic bridge. And this tooth presented with probing pocket depth of 12 millimeter. And the X-ray showed vertical bone loss up to apex. And Professor Fuad has done non-surgical phase in January 2016. And he then managed the tooth by guided tissue regeneration in 2016. He also used the CGF with bone graft, and this is during the surgery. Okay, this is the result that Prof. Fuad shared. He recently reviewed this patient for 5 years, 2016, almost 5 years, post GTR. And if you can see here from this X-ray, evidence of bone formation at this region, coronal region, compared to this one during this line. So as a summary of my talk today, I would like to say that teeth presenting with deep pockets and associated with deep intrabony defects can still be successfully treated with GTR, but we have to be really fussy in case selection. Okay. And based on limited clinical evidence, the GTR teeth can be maintained for up to 20 years as long as the tooth, as long as the patient and being placed under strict regular SPT program. But more long-term clinical studies are needed to strengthen this finding. So with that, I would like to thank you. I would like to thank these 4 lovely ladies, my perio residents, which recently graduated, for managing these cases with me. There are many other cases that will not be included in this presentation. And I would like also to thank Professor Fuad Hussein Abayati for sharing one of his long-term management of GTR with the CGF. Thank you so much.
Okay, thank you, Dr. Farha, for the clear and systematic presentation on GTR. And you can see that 92% of the hopeless teeth scheduled for extraction can be saved.
Yeah.
So, fellows, work for it. And so please think 3 times, not twice, but 3 times before you decide to have the teeth extracted. And think also of the additional benefit, long-term health benefit, and of course, lower cost somewhere along the line. And of course, the fantastic reduction of the PPD that we all aim for.
Yeah. True.
Okay, that's all about today's presentation. That is guided tissue regeneration of periodontally compromised teeth by Dr. Farha. I didn't yet see anything in the Q&A, but please, please unmute and show your face if there is any burning question that you want to present to Dr. Farha. The screen is yours, fellows. I can see a few people here, Prof. Tarabai.
Okay.
Wish her well. I know she's on MC or something like that. And do we have any question? I think it's a very clear presentation. Yeah.
Thank you so much.
Okay, there is one on the chat. Okay, the question is from, oh my God, there's H here. Oh, Hans, did you use anything to stabilize the membrane? Dr. Farha, over to you.
Okay, thank you so much for the question. Regarding stabilization of the membrane, so yes, I know sometimes it's difficult to maintain the membrane, yeah, in its position. So because of that, in most of our GTR, we use bone granules to as a filler of the defect to maintain, stabilize the membrane. I've never used any rigid membrane before. So that's what I use. I hope I can answer your question.
We have a question from Dr. Nadim. I'm not sure where Dr. Nadim is from, but can you please discuss the difference between GTR and GBR and hybrid technique?
And hybrid technique. Okay, first and foremost, the difference between GTR and GBR is that GTR is any regeneration procedure that involves tooth, okay, which involve infrabony defects, whereas the GBR is any guided bone regeneration that doesn't involve tooth, meaning at the alveolar ridge area, which is later for the implant placement. So that is the difference. In terms of the, again, hybrid, hybrid technique. I'm sorry, I'm not sure about what it means here. Probably with my limited knowledge, but I will try to get the answer. I'm sorry. Hopefully, anyone can knows about.
Yeah, any of the audience would have come in for this answer. Do you have? There is the next question. How about PRF and sticky bone?
Okay, PRF. I never tried how to use the PRF before, but from my reading, I understand that it's actually not much different compared to the CGF. Only that the technique in producing the PRF and the CGF is different because in CGF we need to centrifuge the blood in alternating methods. Yeah, but in terms of the quality, studies, there are contradicting studies. There few studies have shown that there is actually no much difference, and there are also studies that say that there is added benefit in using CGF, the one that we use, yeah, because of the presence of CD34. In terms of the sticky bone, even I think, if I'm not mistaken, even in PRF, we can produce sticky bone as what we can get it in the with the CGF.
Okay. Wait, there is a question from Prof. Domleo or Dr. Dong Leong. Okay, just a moment. Very good summary. Thank you. What are your preferred fillers for sticky bone in perio defect management? Different from bone augmentation in implant therapy? Is it different?
Okay, all right. For normally in the clinic, we use BIOS, bovine bone graft as a sticky bone together with the CGF. And so far, it's not much different with the bone augmentation in the implant therapy.
Okay. Next from Hans, is it common to place the CGF membrane first before placing collagen membrane?
Yeah.
I placed the other way around.
Yes. Thank you so much for this question. It's a good question actually. In fact, in the clinic, we admit that sometimes we also put the CGF membrane above the collagen membrane. Okay, depending on the situation. Okay, normally because the in CGF membrane we know there is many growth factors. So if our intention is uh, to make full use of the growth factors for the space, so might as well put the CGF membrane below the collagen membrane. But if our intention is to protect the collagen membranes from any possibility of flap dehiscence after GTR, which is very, very common, then it can also be used there. But in our clinic, sometimes we put above the collagen membrane, and sometimes we put it below, depending on the need.
There is a follow-up question, I presume, from the earlier question. How long will it getting healed? How long will it take to heal, I presume?
The GTR, I presume?
Yeah, the earlier question.
Okay. How long to heal for the surgical side is at least 3 months, 3 months. But as I mentioned in my presentation, for the tooth, for the regenerated tissue to become mature, we better wait up to 1 year before probing or before doing any subgingival scaling, which we afraid might disturb the regenerated tissue.
Okay, I will flip through the Q&A portion. The first one is here. What is your recall interval of SPT after GTR, Dr. Farha?
Thank you so much for the question. So normally we will call the patient every 3 months, to check for patient's blood control. That's first one. And then we also check the surrounding area of the regenerated site for any evidence of for evidence of inflammation. Okay, if there's a bleeding on probing or if there is a deepening of the periodontal pocket. So if there is a presence of any supragingival calculus, we will normally do scaling, and we do oral hygiene reinforcements. If there's a deepening of the deep periodontal pocket, we will do re-instrumentation of the area.
Okay. Hi, doctor. So grade 2 mobilities are not indicated for GTR?
Okay. As I mentioned just now, mobility might disturb the regenerated tissue during healing period. So I found there are literature that even do GTR in mobility grade 2 and grade 3, but they splint the tooth prior to the GTR. But in my clinic so far, what we did, I've been probably a little bit conventional. We, if mobility 1, yes, we will try to do, but even grade 2 mobility, but we will splint the tooth. But of course, this is dose dependent based on the study. With increased tooth mobility, there will be reduced regeneration predictability.
Okay, next, when would you decide to add bone graft together with GTR?
Oh, okay. Normally, in most of the case, I would put GTR unless if the patient presented with very narrow defect and depth, very deep defect, it is okay just to put the membrane because the membrane can will be more secure to be placed there. Yeah, but if not, if the defect is wider, I know that the tendency for the membrane to collapse, we prefer to put bone filler, which is the bone graft. In narrow defect, yes, we can put only the membrane.
Okay, is it, I'm not sure the question is already out. Okay, is it common to place the CGF membrane first before placing collagen membrane?
Yeah, as I mentioned, I think this is the same question as the one before. Yeah, whether to put the CGF membrane first or to put the collagen membrane first. As I mentioned just now, it depends on the situation. If we would like to give the benefit to the surrounding defect area with the CGF membrane, then better to put the CGF membrane underneath the collagen membrane. But if our intention is to protect our collagen membrane in case there's a possibility of exposure during post-surgery, then might as well put it above the collagen membrane so that the soft tissue healing will get benefit from the growth factors in the CGF membrane.
Oh, just the right answer, because for the next question, how
Mhm.
do you manage in case of membrane
Okay.
exposure? Okay.
Okay, thank you so much for your information. Yes, we do have many cases of membrane exposure post GTR. So there are actually protocol in one of the paper. I'm sorry, I couldn't remember the name of the paper, but basically what we have to do if the membrane exposure is within 1 or 2 days period of time, what we can do is just resuture back the flaps. Yeah. If not, if it more than that, we need to excise the flap margin, yeah, to get fresh blood, and then resuture the flaps, yeah. And according to that protocol also, if depending if the condition is worsened, there's a certain situation where we might need to remove some of the grafting material rather than leave it there and become infected if the area become infected. If it's just exposure, it's fine, it's enough for us to resuture the flaps.
Okay, there's a comment from, wait, I see then here, R. Norden. He says, well, summarized presentation, would you consider using just CGF membrane and omitting the collagen membrane?
Uh,
Oh, is
yes,
there a question?
yes. Thank you, Dr. Arnodin. In fact, based on one of the study that I showed just now, there is evidence that comparing between using the CGF membrane with the bone graft and collagen membrane with the bone graft, and they found that there is actually no significant difference. Okay, if you ask me whether I would do that in the clinic, yes, sometimes, especially in patient who has financial constraint for where they cannot afford to pay for both the bone graft and the collagen membrane. So sometimes we offer them just the bone graft covered with the CGF membrane.
Okay, the exposure to the membrane was already discussed. But then
Yeah.
now, what happened if it is the bone graft that's being exposed? Is a
Yeah.
question from Dr. Mina.
Yes, thank you, Dr. Mina. As I mentioned just now, is the exposure is during a short duration of time after post-surgery, which is around 1 to 2 days, it's okay. And there is no evidence of infection to the surrounding tissue. It's okay for us just to debride, to clean up the area, irrigate with a normal saline, and then resuture the flaps. But if there's evidence of infection where probably perhaps patient presented with severe inflammation of the surrounding tissue with probably pus, then we definitely has to remove the grafting materials. Yeah.
Okay, we have one question here from Dr. Juliana Ayub.
Dr. Juliana.
Okay,
For being here.
if the exposure happen after 2 weeks, resuture
Yes.
is still one of the option, or just remove the graft?
Okay, Juliana, thank you for the question. I think perhaps you know the answer for this question better than me. Because as I mentioned just now, there's a protocol, but I'm sorry I couldn't remember the name of the paper and I couldn't remember the details. But I know for the early, immediate management, which is the researcher of the flats. But whether it's after 2 weeks, I think I have to double check back with this paper. I'm sorry, Juliana, I couldn't answer this question for you now, but I'm sure you know the better, you know the answer better than me. Okay.
Okay. Oh, Zati said that the paper is SADC 2004.
Thank you, Zati. Yes, thank you.
Wow,
Thank
this
you.
is all in the group discussion. Okay, refreshing your minds all on the subject. We don't seem to have any more question from the Q&A session and the chat session. So we would like to thank. I guess we will. Let me double check. Okay, we will close the session tonight with giving. To remove this, yes. By stating that we have enjoyed your session, Dr. Farha, and there is a message from your boss here saying thank you, Dr. Farha, and thank you for sharing what you have, your case presentation and all the papers that you have shown to us. It's really refreshing to see what are the things that the periodontist can do outside there, and hope that this will benefit everyone here tonight. Thank you very much. Amy, over to you.
Thank you so much, Atin. Thank you, ICD.
Thank you, Dr. Farah, for the wonderful presentation, and thank you, Dr. Mahina, as the moderator. And also, I would like to thank all the attendants, participants, and tonight I think we have around 85 participants. It's a great number, and also I will share to you for the next speaker. It will be in 3 weeks' time. Okay, allow me to share. Okay, this one is not.
We actually have a lot of questions tonight.
Okay, this will be our next speaker. It's also from Malaysia, and the title will be Oral Cancer and Related Conditions, Understanding Risk Factor Terminology and Competency Requirements of the Dental Undergraduate. The speaker will be Professor Dr. Rosnah Zain, and it will be on the February 9th, so at the same time. So I hope that you can also enjoy this webinar. So please join us, and we will see you again. And I once again thank you to our speaker and also our moderator, and thank you to all the participants. Okay, good night. Have a good day. Thank you.
Good night. Thank you, Amy. Good night.
Thank you. Good night.
Our boss is around just now for a short while, right? Okay, see you sometimes.
Okay.
Bye.